науки, медичні фізики, радіаційні терапевтичні технологи. Слава Україні! Дуже дякуємо, що приєдналися до Modern Brachytherapy course with ABS Experts for Ukraine. Help Ukraine Group, in collaboration with American Brachytherapy Society with speaker support, is excited to present the 10th and the last lecture in this course. And the topic of today's lecture is Plaque LDR Brachytherapy. And we are very happy to host two fantastic speakers, Drs. Wenyin Shi and Firas Mourtada. Dr. Wenyin Shi is a professor in the Department of Radiation Oncology at Thomas Jefferson University and medical director of Radiation Oncology, Jefferson Hospital for Neuroscience. Dr. Shi specializes in the treatment of benign malignant brain tumors, brain metastases, lymphoma, skin cancer, sarcoma, and ocular melanoma. Dr. Shi completed his medical degree at Shanghai Medical University and earned a PhD in pharmacology from University of Florida, where he also completed his residency in radiation oncology. His research focuses on improving therapeutic outcomes and reducing toxicities by integrating molecularly targeted therapies with radiation. He has led several investigator-initiated clinical trials evaluating novel agents such as anti-angiogenic therapies, pathway inhibitors, and immune modulators in CNS tumors, lymphoma, melanoma, and sarcoma. Dr. Shi is dedicated to advancing translational research and expanding treatment options for patients with complex cancers. And our second speaker is Dr. Firas Mourtada. He is a professor and director of medical physics at Thomas Jefferson University. Dr. Mourtada received his master's and doctorate in biomedical engineering and radiation health from Johns Hopkins University, followed by postdoctoral fellowship at the National Institute of Standards and Technology. He has served as principal investigator and co-investigator on numerous grants from NIH, NCI, the Department of Defense, and industry partners, supporting innovations in dose algorithms, adaptive brachytherapy, radionuclide therapy. Dr. Mourtada's research now focuses on improving dose calculation accuracy for external beam therapy, radionuclide therapy. His work includes NIH-funded R01, investigating novel dose calculation methods for targeted radionuclide therapy, aiming to enhance prediction of tumor response and recurrence risk. For his contributions to the field, Dr. Mourtada has been awarded the Fellow of APM, ASTRO, and ABS. Congratulations, Dr. Mourtada. Thank you so much, both of you, for preparing the lecture today. It's an honor for the Ukrainian community to host you, have you with us. And we are looking forward to your lecture on Plaque LDR brachytherapy. I'll stop sharing. And Dr. Shi is currently in China on vacation, so I will play his lecture. He pre-recorded the lecture, and he might be able to join us at the end to answer questions. Okay, so let me share his lecture with the sound.
It is great pleasure to discuss Plaque brachytherapy today. Here are my disclosures. None are related to today's presentation. The goal of my part is to understand the indications, the actual procedure, and the toxicity management of clinical Plaque brachytherapy. So what is Plaque brachytherapy? It is surgically place a small radioactive plaque directly on the sclera of the eye to target the tumor, as illustrated by the figure here, and is often referred as Plaque, ocular plaque, or episcleral plaque brachytherapy. Brachytherapy for eye cancer started as early as 1930s. Back then, the first attempt was using radon seeds for interstitial brachytherapy. The modern Plaque brachytherapy really developed in the 1960s and the 70s. In the North American, iodine 125 used based brachyplaque is the main modality, and on the other hand, in Europe, Ruthenian 106 was developed. And the most important clinical study really established role for eye plaque brachytherapy is the cooperative ocular melanoma study that started in the 1985. It provided standardized methods for diagnosis, the plaque construction, and I-2125 dosimetry. It also established use I-21 seeds in the Combs gold carrier plaque as the most common method used in North America. And the most importantly, the clinical outcome of the Combs 12-year study demonstrated when we treating the UV melanoma with eye plaque brachytherapy really achieve equivalent outcome compared to enucleation for medium-sized choroid melanoma. Over the past decade or so, there's tremendous effort to try to standardize the eye plaque brachytherapy. The first important publication is APM ABS Task Group 129, and this is a guideline for standardizing Combs plaque using either iodine 125 or palladium 103 to provide guidance on the treatment planning and quality management for the clinical medical physicist. And 2 years later, an important clinical guideline come out by the American Brachy Society is to really provide a consensus guideline for the eye plaque brachytherapy for choroid melanoma as well as retinoblastoma. Obviously, this guideline is focused on the clinical aspect. More recently, the modern physics TG221 was published in 2020. It's really provide standardized ocular plaque brachytherapy physics practice and cover a couple different area of focus, including non-Combs plaque, quality management standards, and a framework for general commission process, really lay out the standard for a eye plaque clinic. So regarding the eye plaque design, in North America, as mentioned, the Combs plaques become more standardized and widely used plaque. It used a gold carrier, as you see here. Inside that, it also has a seed carrier, which has placed a slot for the seed placement. And the plaque size vary from 10 to 22 millimeter. And it can load up to 24 seeds with the 22 millimeter plaque. When the UV melanoma is close to optic nerve, they can also use a notch plaque as illustrated in the middle panel, so allow the placement of the plaque deliver adequate dosimetry to a juxtapapillary tumor. Besides the eye plaque, as you can see, there's also other design for the I-125 plaque. For example, the eye physics plaque and the bibic plaque. They have different physics characteristic and a thickness and clinical preference in use. On the other hand, in the Europe, Rossinian plaque was being used, and because the physics characteristic that is used based on the silver plaque rather than gold, but all the plaque pretty much have the same overall design, which emits therapeutic radiation on the concave side, and the plaque serve as a shielding. There's two main group of radioisotopes that's being used. One is the photon emitters. The I-125 is the key isotope that is used most widely in the US and the North American. And the beta emitter, the Ruthenian 106, which is more commonly used in Europe, Japan, and Russia. And the Ruthenian 106 have a shorter penetration and a much sharp dose fall off, so it can create a hotter base dose. As a result, it's only suitable for smaller tumors. And Dr. Mourtada, in his part, we're going to discuss much in more detail regarding the physics aspect of the plaque. For the eye plaque planning, it all started with an extremely careful eye examination by the ophthalmologist. Based on all the clinical examination, imaging evaluation, ultimately they will generate a very detailed fundus graph, as you see at the lower left corner, which outline the tumor, provide information about base diameter, as well as the height of the tumor, and also relationship to the optic nerve and the fovea. And in our institution, we use the iPhysics iPlaque simulator for radiation treatment planning for the plaque. As you can see, this is a juxtapapillary tumor, which means the tumor is very, very close to the optic nerve. Based on that, we choose a notched iPlaque, allow the seeds to be better placed to deliver adequate dose to the tumor. And based on that, we will carefully evaluate all the isodose plots to make sure we have adequate coverage. For UV melanoma, the dose we use in our institution is 70 gray to the tumor apex. And the depth is defined at the tumor height from the inner of the sclera. And we also plus 1 millimeter, which accounts for the sclera thickness. So it is the actual depth from the apex from the outer surface of the sclera. And for iris melanoma, we usually use a very specific depth of prescription due to the anatomic characteristic of those tumors. On the tumor base, we also routinely add 2 mm margin, and we are carefully looking at the key normal structures and try to keep those constraints to mitigate potential long-term, short-term toxicity. We try to keep the optic nerve disc less than 650 gray, and the fovea dose less than 60 gray, and the sclera dose less than 350 gray as much as possible to reduce the sclera thinning or sclera ulceration risk. So afterwards, we'll generate a very careful and detailed dosimetric table to make sure all the parameters are meeting our goal before everything is approved for clinical delivery. I will briefly describe the iPlaque surgical procedure. So this is done under general anesthesia. And as you can see, the procedure will start with peritectomy. Basically is a conjunctiva incision and dissection to open the conjunctiva and expose the sclera. And then the ophthalmologist will use transillumination, basically put a light source 180 degrees from the tumor, and then you will see the shadow on the sclera. And based on the transillumination, the eye surgeon, the ophthalmologist will outline the base of the tumor by a marker on the sclera. As you can see, this is how it is marked after the transillumination, and with the blue marker outline the base of the tumor. Afterwards, the ophthalmologist will place a dummy plaque. The dummy plaque, which is also shown on the picture here, is a plastic plaque with no radioactive source in it, but it's exactly the same size and shape as actual plaque. So the ophthalmologist will place the dummy plaque over the sclera and focus, make sure it fits the outline the tumor well with appropriate placements, and this allowed the ophthalmologist to achieve the optimal plaque placement without exposed to the radiation. So after the dummy plaque placement is happy, the ophthalmologist will put 2 sutures in over the ears as shown for this plaque, but they will not tie the suture. The suture is placed but not tied. And then afterwards, the dummy plaque is removed and replaced with actual plaque with radioactive seeds. And then the ophthalmologist will quickly suture this, tie the suture and cut the suture, then close the conjunctiva. As you can see, after the procedure, the plaque is covered by the conjunctiva. And in our institution, after the plaque placement, we also have the patient wear another external lead shield to further reduce the radiation. So here's a question. What are the most common indications of the iPlaque brachytherapy? A, medium-sized uveal melanoma. B, circumscribed choroid hemangioma. C, retinoblastoma. D, choroid metastasis. Or E, all of the above. Currently, the most common indication active seed.
Wait until 80% will answer. So you kind of like peeked into the next slide and you kind of know the answer now. But let's see. 77%, few more answers, please. Okay, great. 81% answered. I'm ending the poll and sharing result. So majority answered all of the above, actually, 63%. And okay, so I'll stop sharing. Let's listen.
External lead shield to further reduce as a height between. Most common indication for eye plaque brachytherapy is UV melanoma, particularly the median-sized UV melanoma, which is defined as a height between 2.5 millimeter to 10 millimeter, and the basal diameter is less than 16 millimeter. And those UV melanoma treated with eye plaque therapy with very high local control success rate and also eye preservation success rate. Larger UV melanoma, which has height more than 10 millimeter of largest basal diameter more than 16 millimeter, in some selected patient, they may still be a candidate for eye plaque brachytherapy, but because of the large size and the potential compromised plaque coverage, they may have lower local control and or potentially higher rate of toxicity, including poor visual outcome. Other circumscribed tumors, such as a circumscribed choroid hemangioma, choroid metastasis, or retinoblastoma, can certainly be treated with brachytherapy eye plaque as well. In a very, very selected cases, such as tumor in the surface of the eye, like a conjunctiva, squamous cell carcinoma, melanoma, which is circumscribed and well, limited to the size limits by the plaque, it may be considered if they are not a good candidate for surgical removal. Now we have a little bit in-depth discussion of the uveal melanoma. We're going to first start with some anatomy. The uveal layer of the eye consists of an entire vascular layer of the eye. So it sits between the retina and the sclera, and it contains blood vessel, melanocytes, and a connective tissue. And it consists of three parts: the iris, ciliary body, as well as the choroid. And the uveal melanoma arises from the dendritic melanocytes in the uveal layer. And although uveal melanoma is very rare, but it's actually its most common primary intraocular malignancy in adults. In the US, the incidence is roughly about 5.1 per million new cases a year. Something to be aware that uveal melanoma has very different biological behavior compared to its cutaneous counterpart. Most patients are diagnosed between the age between 50 and 70. The median age is now over 60. But in the iris melanoma, the median age of diagnosis is tend to be a decade earlier than the posterior UV compartment, made due to the easier clinical detection of the melanoma due to the location. It is more common in male compared to female, and the 98% of cases occur in the Caucasian population. As you can see, some predisposition factors, including light eye color, fair skin, and those are all reflecting the Caucasian patient population, and pre-existing nevus or ocular melanocytosis or melanocytoma are some predisposition factors. UV melanoma potentially can lead to increased ocular pressure and cause glaucoma or painful eye and vision loss and later develop metastatic disease. But at the time of diagnosis, only 2 to 3% patient are present with metastatic disease. Mass majority of the patient are presented with localized disease in the eye. And the UV tract is a vascular structure without lymphatic channels. So tumor spread is mainly through bloodstream. Lymphatic spread is very rare. And so sentinel lymph node biopsy is not necessary as a part of the staging workup. Despite there's only 2 to 3% of patients present with metastatic disease, unfortunately, over the course of disease, about 50% of patients will develop metastatic disease. The most common site of metastasis is liver, followed by lung, bone, and the brain. Very careful examination is crucial to thoroughly evaluate the disease extent and optimize the treatment. So evaluation including examine the contralateral eye to make sure there's no involvement, and often including a direct osmoscopy evaluation. Slit line evaluation can look at both anterior posterior segment eye. Transillumination can also evaluate the diameter of the tumor. And the fundus photograph is important for documentation. Fluorescent angiography using fluorescence dye that's injected, and the picture will be taken to evaluate the blood flow in the retina, and this illustrated by the photos here. Regarding imaging analysis, ocular ultrasound is very, very important. Ocular ultrasound consists of 2 parts, the A scan and the B scan. The A scan use high-frequency ultrasound, that's to image anterior segment in detail, as you can see on the panel A, the middle panel there. And the B ultrasound uses low-frequency ultrasound to image the posterior segments, really very useful to evaluate the size, location, and involvement of the uveal melanoma. The ocular ultrasound has long been considered gold standard for measuring uveal melanoma, tumor diameters, or thickness, basal diameter, as well as monitor changes. But more recently, the optical coherent tomography really become a more reliable and accurate technique to evaluate the tumor extent. The ocular coherence tomography uses near-infrared waves to capture images. The most striking feature of the OCT is it can actually capture a very high resolution detail of the retina, often linked to its histopathology findings. As you can see, the sample images here, it actually can very detailed illustrate each layer of the cell structure of the retina, the choroid layer as well as sclera, and then you can very accurately assess the tumor involvement or subretinal fluid. So it's become a very, very important technique. Besides that, standard imaging studies such as CAT scan, MRI scan is also important. It can evaluate extraocular extension, orbital invasion, as well as brain metastasis. Of all the uveal melanoma, the choroid melanoma is most common, accounts for about 90% of all cases. They are usually asymptomatic at early stage, but when they start to grow and large enough to affect the neighboring ocular structure, it can lead to symptoms such as blurred vision, floaters, visual field loss, photophobia, or severe pain due to increased ocular pressure. Ciliary body melanoma is very uncommon. It's only about 6%, but it's its most aggressive form. And it's usually remain hidden behind iris and grow to a large size until it can be detected. And ciliary body melanoma can also grow transclera and can spread locally to the orbit or conjunctiva. And also they can present with those dilated blood vessels on the sclera surface, which underline the tumor. And the growth of the melanoma sometimes into lens may produce subluxation, astigmatism, or cataract. Iris melanoma is least common and the least aggressive. It can present either a circumscribed or diffuse fashion. And for the circumscribed type, it's most commonly arise in the lower half of the iris. That's kind of happening in about 80% of the cases. And in order to classify the uveal melanoma, there are different classification or staging system. The Combs classification system is simple and widely used. It basically defines the size of tumor to be small, medium, or large based on the height and the maximum basal diameter. And it's highly related to the outcome and very important to direct therapy. So it's very commonly used in clinic. AJCC staging system is more complicated, and this is the T category table based on the thickness and the basal diameter size. It break into 4 different categories, and based on the T category and other factors, there will be staged T1 to T4, and this is the staging grouping of the AJCC system for choroid and ciliary body melanoma. Just keep in mind, majority of those cases when they are initially diagnosed are early stage. As you can see, based on 2 large series over 10,000 patients, stage 1 patient about a third, and close to half of stage 2 patient. And certainly the staging group is very prognostic, significantly correlates with overall survival. Iris melanoma, due to locations, they are staged differently. Here is listed for your reference. The next question, which patient is the most appropriate candidate for iPlaque brachytherapy? A patient with a small to medium-sized choroid melanoma confined to the eye, a patient with a large melanoma that with extensive extraocular extension, a patient with a painful blind eye due to neovascular glaucoma from choroid melanoma, or a patient with metastatic uveal melanoma to the liver.
Okay, a few more answers, please. So we have 82% answering. Thank you. I'm ending the poll and sharing the results. So majority of you answered A, patient with small to medium choroidal melanoma confined to the eye. So let's listen to the answer. I'll stop sharing.
So let's take a deep dive into the correlative ocular melanoma study or the Combs trial. So that started in the 80s and 90s. It's designed to assess effectiveness of 2 treatment modalities for choroid melanoma, basically enucleation or iPlaque brachytherapy. So the patient selected, including all the treatment naive choroid melanoma without apparent metastatic disease. Here is the overall schema of the Combs trial. So the study categorized patients into small, medium, and large uveal melanoma. For small uveal melanoma, they are observed. Medium-sized uveal melanoma, they are randomized to enucleation or iPlaque brachytherapy. But for the large uveal melanoma, all the patients will have enucleation, but they're randomized to enucleation only or pre-enucleation external beam radiation treatment of 20 gray. This is outcome for the small melanoma that was observed. And of the 204 patients over the time observation, 21% of patients grow to the size eligible for trial, and 31 patients will grow to the size eligible for trial at 5 years. And but overall, melanoma specific mortality is very low, only 1% of 5 years. And there are certain risk factors predict a tumor growth. The next question is, what is local control rate of median-sized uveal melanoma treated with I-plaque brachytherapy? 90%, 70%, 50%, or 30%?
Okay, waiting for a few more answers. 81% participating. Thank you. I'm ending the poll and now sharing the results. So the answers are split between A and B, 90 or 70%. Stop sharing.
So hopefully you can answer this question after we review the Combs outcome data. So for the median-sized uveal melanoma, as discussed earlier, it's randomized patient into enucleation and I-plaque radiotherapy, but this is I-125 I-plaque, and they prescribe 85 to the 85 grade to the apex. And one of the TJ study later published to evaluate the prescription, and it prescribed to a uniform matrix, but when we take the heterogeneity into consideration, it delivered about 75 grade to the apex. Okay, and there are some key inclusion-exclusion criteria. If the patient who have significant involvement of the cerebral body or extensive scleral extension, those patients are not eligible. And as mentioned, they use the Combs plaque, which is illustrated here. They're different size from 10 to 22 millimeter. And this is the gold plaque with seed holder. And the prescription is 85 grade to the tumor apex. A total of 17 patients enrolled in this median size randomized portion. And it's 1-to-1, so over 600 patients in each arm. And the local failure for the I-plaque group is 10%, and the 12.5% of the patient, the eye require enucleation, mainly due to treatment failure, but also due to toxicity or other reasons. At the 5-year, the overall survival is equivalent, 81% versus 82%. And a 12-year overall survival is also equivalent, 59% versus 57%. So this really established the role of I-plaque in the management of the median size uveal melanoma. Old age and the large maximum basal tumor diameter are the primary predictor of time of death. Regarding vision outcome, at 3 years, 30% of the eye had 6 of 12 or better vision. The median vision acuity of 20/125 compared to 20/32 at baseline. So there's significant vision impairment in significant portion of the patient. And overall, about 45% of patient has a meaningful visual impairment. The visual retention was most independent on tumor thickness, tumor location, with respect to optic nerve, fovea, as well as cerebral body and age, which overall are pretty equivalent. So what about the juxtapapic choroidal melanoma that next to optic nerve?
Just to conclude, the correct answer was A, 90% local control.
Nerve, and this is 650 patient treated with I-plaque with tumor less than 1 millimeter from optic disc. The glow retention rate is very high at 84% at 5 years, indicating a successful local control, but more patients experience vision decline. As you can see, at 5 years, more than 54% patient has visual acuity less than 2200, and the loss of 5 of the visual acuity line was happening in 45% of patients. And if the juxtapathogenic choroid melanoma overhanging the optic disc and treated with eye plaque brachytherapy, and the vision outcome, as you can expect, it could be even worse. As you can see, the visual field acuity of 2200 or worse happened about 77% of patients, and visual loss more than 5 Snellen lines are about 63%. And the overall, even though the tumor recurrence rate is still reasonable, about 10%, similar to other data, but the enucleation rate is higher, indicating higher toxicity. In a comb study, large size choroid melanoma, those tumor has apex height is more than 10 millimeter or largest basal diameter more than 16 millimeter. And those tumors are randomized to enucleation or radiation followed by enucleation. The radiation dose is 20 gray in 5 fraction, but there is no difference in overall survival or local control. So pre-enucleation radiation treatment is not recommended. So here is the summary of the Combs trial based on different size of the choroid melanoma and the key finding. I included here for your reference. In the last couple of minutes, I want to briefly discuss on a key complication consideration for eye plaque brachytherapy. And we'll start with discussing the posterior segment complications. The most important one will be retinopathy, and it can occur in about 42% of patients. The therapeutic intervention is basically intraocular injection of the anti-VEGF or steroids, and could be prophylactic use in high-risk patients. And in our institution, the standard regimen will be intraocular injection of anti-VEGF agents such as Avastin or steroids every 4 months for a total of 7 years. And by this regimen, the retinopathy risk can be reduced from 40% to around 20%. There's also a small percentage risk of optic neuropathy, particularly when you are treating a tumor that's very, very close to optic nerve, and sometimes it's inevitable due to the tumor control consideration. And there are some treatment considerations such as steroids and hyperbaric chamber, but in general, optic neuropathy is often non-reversible. So certainly you want to optimize your dosimetry to prevent its occurrence, but in certain situations, due to the tumor location, that is an avoidable toxicity. The visual acuity loss, which we discussed in the Combs studies, as you remember, about 45% or 49% will have significant meaning for vision impairment, and usually just treating the underlying causes. On the other hand, there are some radiation complications for the anterior segment. The most common one will be cataract. The cumulative risk is actually relatively high. It's occurring in 68% in 5 years, and the incidence is going to be even higher if the dose to lens is more than 24 gray. But the management is very much similar to the age-related cataract for lens replacement. So it's very, very manageable, fixable toxicity. Neovascular glaucoma can occur, and the neovascular glaucoma is actually one of the most significant causes for enucleation due to painful eye. And certainly all the glaucoma management with pressure-lowering medicine, photocoagulation, and the filtration surgery are all appropriate. And the radiation scleral necrosis can occur when the scleral dose is very high. That can lead to scleral thinning or necrosis. And often they are minimal and stable, and need observation will be sufficient. But in severe cases, scleral patch or graft may be considered. And extraocular muscle dysfunction and diplopia is often due to the muscle manipulation during the procedure. And often for mild cases, they can be observed, but severe cases may require some surgical correction. So a quick brief summary for the first part of the discussion. Plaque brachytherapy may be used to management for uveal melanoma, retinoblastoma, hemangioma, and choroid metastasis. Today's discussion mainly focusing the uveal melanoma, which is the main indication for plaque brachytherapy. And for medium-sized uveal melanoma, plaque brachytherapy offers excellent tumor control success rate and a survival rate comparable to enucleation. And it's a very effective eye and a vision preservation treatment for patients with intraocular tumors. Thank you very much.
Thank you so much, Dr. Shi. Unfortunately, he could not be with us today, but it was a great recording, great lecture, very logical, learned a lot. So, Dr. Mourtada, you please share your slides?
Hi. Yeah, thank you for inviting me, and I'm so honored to speak to the Ukrainian radiation oncology teams. Hopefully one day we could meet and be in peace soon. Let's pray for that.
Yeah, so, we all hope for that.
Yeah, we hope, yeah, your trouble, we feel it. Yeah, let me see if I could share, and let me do, swap. All right. Can you see my screen?
Yeah, looks great.
Thank you. Great. So I also, this is my disclosure, nothing related to ocular melanomas. Just want to mention that. So in the next 30 to 40 minutes, I hope to go more in details about what Dr. Shi described about the way we do brachytherapy for these wonderful treatments. You saw, I mean, if you catch it early to mid-size, you could be, I mean, I'm seeing over 90% control rate. So that's phenomenal. All our patients up to brachytherapy over nucleation. Nobody wants their eye out and putting a prosthesis, really. So really, we want to say this is a very important modality, and it is fairly affordable in terms of cost compared to other modalities for radiation oncology. So, and since here we are going to focus really on two aspects: the beta particle sources you've heard mostly in Europe, but also we have few centers here that have been utilizing ruthenium. Rhodium. Rhodium is the parent of ruthenium. So this is really, it's a secular equilibrium inside the coated plaque, and we'll talk about those. So the maximum energy of 3.5 mega electron volt MeV, and versus the iodines. The iodines and palladium is not as common. I never really done a palladium eye plaque, but you could kind of see it's a low energy photon emitters. So, and Dr. Shi mentioned to you, these are very quickly, just to mention, actually, I was honored to be on both reports. In 2012, we had the dosimetry, looking at comms, looking at how you do that and get consensus on how you do treatment planning for that. And then we followed it in few more years, in actually 8 more years. Things have changed because we wanted to really write more consensus for how you do beyond comms. Basically, think about it is that what else can you do beyond comms? How can you improve on that? So for TG221, really, it's very still up to date. I believe you could use it. You're looking at radiation safety considerations, source calibration methodologies. If you have a ruthenium plaque, what you do. If you have an iodine, how do you calibrate those? Looking at the applicator itself, and the commissioning processes in your treatment planning system, and then imaging QA. You know, as you've seen that we have different ways of doing imaging. Although we really don't dwell on MR or CT imaging, we just mentioned mostly the ultrasound and what's required by another task group that describe those details. And we talk about treatment planning strategies and some of those details. So I won't go into all of that because of the sake of time, but this is kind of where I want to focus my talk today. The number one is the beta plaques. We'll talk about ruthenium plaques. 2 is the COMS. Those are the classical solutions. And 3, if you're going with custom plaques. And the reason I talk about custom plaques is that's really at Wills Eye Hospital here with Thomas Jefferson. Mostly the Wills Eye Hospital, you can see here, they do utilize this concept, and I want to present it to you. So with that, let's go to ruthenium. Half-life is almost a year, so that's great, right? You could have. I've commissioned actually at MD Anderson in 2005. I've commissioned the first ruthenium. I believe it was in the USA. I do have a beta particle expertise in terms of dosimetry and calibration because I did my postdoc at NIST, the National Institute of Standards and Technology here in the United States, and we were very much focused on that. So I was able to really characterize that. But why we think it is important to look at ruthenium is because the percent depth dose in tissues approximately is going to fall at 5 to 10%. It will be 5 to 10% at 7 millimeters. So it's very quickly falling off. Usually in the FDA approval for up to what tumor epics, you shouldn't really exceed 5 millimeters. Although in Europe we've seen up to 10 millimeters or even 12 millimeters. I've seen in Germany they have treated, and that's what Dr. Shi mentioned about sclera doses, and I'll show you an example in that. And usually the tumor base is limited to approximately 15 millimeters because these plaques, they're not as large as the COMS plaque. So this is actually from Fluss from Essen, Germany, to really give you an understanding for the same prescription of say 100 gray at the apex here. This apex is definitely more than 5 millimeters, about maybe 10. You could kind of see your tumor base of sclera is receiving 2,200 gray. That's an incredible amount of sclera dose. But the opposite retina is only 1 gray, where if I go to this depiction, same tumor, same prescription, the sclera you see is 440 gray, so definitely much lower than the 2,200. Still high, but it is much lower. But the opposite retina and the lens, everything else is receiving a good amount of dose. So with that, that's where we kind of realize that the dose distribution, if you go here versus here, which one you want to do. And also notice the thickness of the plaque. The ruthenium is much thinner, so the ocular surgeon actually preferred these plaques. And that's why I was asked from when I was faculty at MD Anderson years ago, I was asked to commission that because of those characteristics. So, and you can see that this is kind of cross-section of ruthenium plaques. It is still considered sealed source because the ruthenium shell, it is 0.2 millimeter of coated foil. And there is it's a beautiful, when you get these, you open them up brand new, it's like a mirror. You see it's a silver window. Well, until you send it to sterilization, and then you get disappointed because your mirror becomes very murky. But it's really interesting plaque, and I've really admired the technology on how they plated that ruthenium. It's very important that it is fairly uniform, and in fact, there's a QA test you could do to check that uniformity. These are the different. If you look at BBIGs, I just highlighted the few I commissioned at my institution years ago at MD Anderson. The CCB is the most common here. It is 20 millimeter diameter. The effective, it's slightly less than that effective but distribution, but 20, the outer diameter of this plaque. It was my most, and then obviously there's a COB, that's the notch plaque. CCA we only use for pediatrics. That's only 15.5, I believe, 15.5 millimeter. But anyway, you could really, I wouldn't recommend you buy all of them. They are fairly expensive, but remember, you're going to only use them. You could use them a year and a year and a half, depending on how long you could tolerate really if source is decayed. But they recommend it to be used for about a year and a half. So in TG221, this is actually a spreadsheet I provided in the report, just a 1D dose methodology. It's fairly straightforward. You really don't need too much with this. This is very quick. Obviously, you could turn the same plaque as long as you re-sterilize it and it's ready for the next patient. The prescription here and how you enter it is just a 1D dose methodology. I won't go into the detail other than if you have any questions about it, please reach out to me and I could provide you with this spreadsheet. And so the other alternative, which is also nice, is the same plaque simulator that's provided by BBIG as well. They do have a treatment planning system that calculates these doses, and you could select these different types of sources. The way this is used, this is the Melvin Astrahan. This is a paper that was published on how he did the dosimetry using a patch source model. This is over multiple patches inside the plaque on the concave side of the plaque. So imagine this, because you could not really do a kind of a TG43 formulation. This is a very complex geometry. So he invented this really wonderful methodology of about 300 to 1,000 uniformly distributed active sources or patches that conceptually mimics a point source dose function, and it also attributes to an anisotropy term, because at the end you will have some you have to account for absorption and scatter. So really this is a methodology. It's not just in water, it is accounting for some of the perturbation of the plaque itself. So this is, I think this is, there's a methodology there on how you have specific BBIG measured data that you enter to calibrate the patch source model in the TPS. So if you're gonna use this, please follow the distribution. And this is examples from the paper, calculated versus measured percent depth dose on this panel here, figure 4. Figure 6 is the isodose distributions in black lines in a plane. This is a CCB plaque. So he's comparing the Monte Carlo calculations in gray lines to the TPS, and they're fairly reasonably agreeable there for beta sources. So that leads me to my question relative to iodine 125. Ruthenium-106 iPlaques delivered doses are similar to the sclera and opposite retina point, higher to the sclera and opposite retina point, higher to the sclera and lower to the opposite retina point, or lower to the sclera and higher to the opposite retina point. And obviously, I'm assuming the same tumor epics prescribed dose for all of the, whether it's iodine or ruthenium.
It's a great question.
Makes you think.
So, yeah, it makes you think. That's a great comparison too. Yeah. So Europeans are mostly using ruthenium still, and Americans using COMS. That's the case. Most Americans.
That's my, unless something changed in the last few years, I have not heard that there has been a shift to iodine there. Definitely it has its advantages surgically, and especially for pediatric. I've done some infants who you cannot have done a COM plaque because it's thick.
Yeah, too big.
Yeah.
Waiting for your answers. There's a few more.
Yeah, we're at 70%. I see it. Yeah, this is really nice.
Yeah, you can use it for your lectures.
Yeah, I'll learn from you.
And we learn from you. Few more answers, please. So waiting for 80% participating. Okay, thank you so much for answering. I'm ending the poll, sharing results. So majority answered C, higher to the sclera, lower to the opposite retinal point.
Which is the correct. So yeah, so think about beta particles. They are much higher dose gradients. So definitely for the same depth, say 5 millimeters to an apical height, you're gonna definitely produce higher doses, and it's more conformal. It's definitely that's a very interesting. There's not either. It's good and bad, right? So each one has advantages, I think. So I'll continue now. So let's now talk about comms. Let's see what comms that you've seen this. The idea of that the comms really you have the gold backing, you have the elastic inserts that you place these, and they are in a coordinate systems that are already defined. You order these, the elastic inserts you use one time. You throw them away, you don't reuse them, at least I didn't. Obviously the gold backing you have to, it's expensive, you can't just throw those away. So yeah, those are fairly well known. In TG129, we provided you the consensus for each plaque size, the XYZ, so you could put this on a spreadsheet and calculate the symmetry using TG43 formulation. I think prior speakers in Brachy, they talked about TG43. Is that right, Natalia?
Yes.
So the concept is that you could produce the symmetry. You could put those coordinates in a treatment planning systems like Brachy Vision and calculate. So plaque size is chosen to give 2 to 3 millimeter margin around base of tumor. So what I mean by that, if I have, let's say I have in the imaging, the doctor says it is 14 millimeter diameter, maximum diameter, you'll add 2 millimeter on each side. That will be 14 plus 4. So you're looking, maybe you will pick this 18 millimeters. I mean, sorry, so 18 millimeter will be the minimum you would want. Sometimes we do use larger but those are the thing is that you will size it based on that margin. Apical height defined to be from the inner sclera, so you always have to remember to add another millimeter because the sclera itself, on average, is a millimeter. So we don't really measure that for each patient. We assume you add a millimeter. And in comms, they do not exceed the 10 millimeter maximum. And I already mentioned about the sclera thickness. They're 85 gray. This is in water. And they really actually have an algorithm. So 85 gray to the apex for apical height larger than 5 millimeter. If apex is less or equal to 5, prescribed to 5 millimeter height. And look at the dose rates. These are low dose rate, LDR, which is, if you recall, it's about 50 centigrade per hour. But you can see this is the range of apical of dose rates at the apex that you would expect following up comms. And this is, they provide that just to really simplify things to you to understand these other organs at risk. And then we do talk about, all right, so it's 85 gray in TG129, but this is really TG43, so it's all in water, no effect for the perturbation of the plaque. So they do recommend in TG221 to start looking at heterogeneity dose calculation. It's nothing wrong with staying with TG43 as long as you know really an 85 gray prescription it's more like 75, like Dr. Shi mentioned to you. So what do we do today? We could use TG43 hybrid techniques with conventional TPSs. You could do superposition of a single source dose distribution with appropriate semi-analytic corrections for plaque materials heterogeneities, and that's what the plaque simulator software is all about. So really, and if you commission, there is good work that has been done to, if you commission that, you could have reliable dosimetry coming from it. Just another reference about how this is done in Plaque Simulator. I won't go into the details other than to give you the reference that it allows distance-dependent dose correction factors, TFR, that will, like this is for iodine, for example. So these correction factors, and there's studies that shows its accuracy is reasonable relative to Monte Carlo simulations. In fact, here's some of the simulations we've done in the past, and the solid lines. These are this is the Monte Carlo. You could see versus a prescription at 85. So you could see it's pulling. It's less dosing in reality. This is it came out from just the study to understand where they were. Remember, COMS started in 1985, so it didn't have the accuracy we have now in our treatment planning systems. So in summary, for task group 221, homogeneous dose calculations using TG43 or the 1D approach for beta plaques, like I showed you that spreadsheet. This is your minimum. Heterogeneity dose estimations or calculation using model-based dose calculation algorithms or Monte Carlo or something, appropriate corrections will be wonderful to give you better dosimetry. Standardization, specification of target volume, including planning margins, established dosimetric constraints for organs at risk. Dr. Shi showed you some of that. So with that, our last question is, COMS dose prescription to tumor epics is 85 gray in water. What's the actual dose delivered? Is it 100 gray? Is it 75 gray? Or is it 50 gray? Or even higher, 120 gray? Right, we need a few more answers.
It's amazing that by the end of the lecture, 70 people joined, so that's great.
Yeah, going up rather than down.
Yeah, that's good. That's good sign. So, okay, we have 67% answering. I would like a little bit more answers, please, if you can. Okay, so ending the poll and sharing results. So majority, 58% answered B, 75 gray.
That's a correct answer. So it's really, it's less, and again, it's what scatter, and that backing, that gold is really taking away some of that energy. So yeah, that's great. Again, COMS planning using water can be commissioned for all seed models in variant brachyvision or Plaque simulator. Now remember, just if you have electron center, that you can't really add other than the iridium source HDR, so you can't add another seed model like a iodine seed there. Just a comment. Second, independent calculation can be developed in-house or using commercial QA software. So this is kind of my spreadsheet in the old days. You could really these are the XYZ I mentioned from iodine from TG129. You could enter that, and you could produce fairly good kind of a second caps. And these are the results. This is to the epics to 5 millimeter depth. You could do it to the opposite retina. You could do it to any other structures as well. So let's talk about now what we do here, just because it's unique and I want to share with you. We have many different, these are custom plaques. They were, remember the Shields, Jerry Shield and Carol Shield? These are the surgeons who started this in the 60s. This is really nothing new, but we have been, since I've joined Jefferson 3 years ago, and we created a wonderful team to actually take this to the next level on how we do things. So these are really, there's a lot of different plaques and different disease types that Dr. Shi mentioned to you. So it's not just choroidal melanomas, right? So we have it's a lot more than that. So how do we do this? Because we actually have a high volume, we treat 6 to 7 plaques per week. That's about 335 patients per year. It's an incredible volume because international patients come from everywhere to get treated. And so we really have to, they could come be seen by Monday, and what I'm showing here is that it's a circle in a 1 week. This is I'll call it eye plaques on steroids. I've never seen anything like it. So I mean, usually I used to do eye plaques. It takes 3 weeks, 4 weeks to order the iodine seeds to build it, but this is really very very quick. So they are seen, say, in a previous week. Patient documents go from Wills Eye Hospital. They come to Jefferson by Monday, Tuesday. Our team is doing the planning, physician review, about the same time. We build the plaques by the end of Tuesday. We do the build check and QA on Wednesday. We insert all our plaques 7 a.m. As you could do 7 plaques in about 3-4 hours. We have 2 OR stations, and they actually get 2 patients almost at the same time. Explants usually a Monday afternoon, or if it's a 7-day treatment, sometimes if it's a larger tumor, we actually explant on Thursday, and then we finish up. So that's kind of the circle there. I'll dwell on treatment planning. Dr. Shi showed you what we get from the ocular oncologist. This is their requisition. They suggest kind of, it's always iodine 125 here. We don't have ruthenium here, but they do suggest, like, obviously they give us the sizes, and what plaque size they like to see done on this patient. Of course, we could change that if we feel planning is that we could suggest something else. So just learn the fundus diagram. This is the publication here by Evans, 1993. Really shows you the anatomy of the right eye in a transverse cut, and how it relates to a fundus view diagram. It shows 2 tumors labeled A and B located on the transverse. Great circle are shown in both views, so you could just learn how to do this. As a physicist, as a physician who's trying to do this, it's important to understand the language of the ocular oncologist. So they really would like to show that. And then we use Mosaic for record and verify, and we have made everything here electronic. This is a recent effort we've done. We went away from paper, and so you really, the physician here, the implant shows this is the left eye. She wants the 70 gray. Now remember, we don't do 75 gray. We actually do 70 gray prescription, and that's because we do heterogeneity dose calculation in Plaque Simulator. So that's more about 80 gray if it's just in water or about. So this is just so we decided on a prescription and how it looks like, and then we carried the treatment planning forward with it. This is the Plaque Simulator. This is you could kind of see why it's powerful to have. You don't have a elastic insert that constrain you. It's based on the shape of the plaque of the tumor. We really we could slide these seeds anywhere we want. So you have much more degrees of freedom to place these sources relative to optimize your dosimetry. So think about it that you are much freer to do it. Of course, how we do this is that we use these seeds are sitting on the inner concave surface of the plaque. And so you have to have a methodology on how you glue them. It's important. It's a process of that, and I will show you some of that. But anyway, the physician and the physicist really look at these profiles, and it's just like any traditional treatment planning system. We are watching for margins. We are watching that did we cover tumor, and if there's an optic nerve, this case doesn't have one. so close, but if we do, we then optimize the seed location. We could move that seed and recalculate, so it's almost like inverse planning. It's pretty cool. This is the prescription and OAR constraints Dr. Shi already mentioned, so I don't have to repeat them, but they're here for your information. That's what we do. It's not the national consensus, but I think a lot of it is in the ABS guideline as well. Plan check assessment for physics, because we, at the Plaque plan check, we do go through certain things, what we feel important that if somebody missed. So this is a second check by not the planner, and then this a second physicist or second person who would check these things to make sure the quality control is achieved. Before, in terms of building the plaques here, we have equipment. You need a hot lab with appropriate radiation science and secured access. You need a negative pressure hood for seeds for plaque assembly. That's important if you're gluing these, because then there's chemicals that you don't want to really inhale. So it's important to have the negative pressure. There's an L-shaped shield, obviously for radiation protection, and we use tungsten shielded gloves. So this is kind of our hood, and this is the L-shaped shielding there. You could see how we could build these plaques behind in a convenient manner. And these are the sources. We have different batches of iodine seeds. The reason we do that, because we order these every 2 weeks. We have 35 seeds per batch, so we could really then have different seed activity for different tumors heights and scenarios. So this is kind of like we are not waiting for the vendor to, not per patient we order. These are batch ordering and system. We have a system to actually track these things. These are our custom plaques. Actually, not all of them, because when I took this picture last week, there's 7 of them are missing because they're actually being used then. But you could see how we track these. They have certain numbers. And we published not too long ago the economics about, do you reuse or not reuse? I think and we showed the cost saving, even in FedEx shipping. I mean, imagine if you are just using those seeds for one patient and then throwing these seeds away versus actually recycling them. We could actually reuse a seed 3 to 4 times. So that's kind of showed, this is a nice paper to kind of show you how we do things here. And then in terms of build check and QA, I mentioned about independent second dose calculation. QA is calculated using TG43. You could either do it on a spreadsheet, or this is another software within Plaque Simulator, but separate TG43 parameters that we could plug in and compare those to what we have. Plaque insertion removal date and elapsed time should match plan. No patient information is included. So while we do also, we do a lot of QA to make sure you have everything ready in the OR the next day, and it is always helpful. In terms of seeds, if you're receiving this new batches, this is just the task groups that TG43 recommendation of assaying 10% of the seeds. If you don't 10%, you could also pay the vendor to have an independent calculation or independent assay. So all your seeds could be assayed by a third party. Either way, that works. We have recently published a paper to tally. This is a 3D printed kind of a conical holder. You could place the source, the seed that's already assembled inside a well chamber, and you get a response in the chamber. The fact here is that we're trying to do is that make sure that when the plaque goes to the OR and comes back, that relative response is just decay. We did not mess up because we have different batches of seeds. So we want to say, okay, this plaque is from this particular batch. So we could really fairly track it here in a nice way, just to, it's another way to track where those seeds are coming from. The plaque implant, that is Thursday. We produce this summary sheet because remember we have about 6 to 7, so we really need to know all these, which one goes first, which one, you know, we tally. This is a good organizational way to know if you're coming with multiple patients, is to have all the characteristics of their plan. So this is the team. This is just in the OR, you have a mobile cart, 7 meters, lead eye shields. You can see the lead eye shields here. The dummy plaques, you need the dummy plaques. Don't forget those because, as Dr. Shi mentioned, they're important. You need to see that before you place the plaque, you need the dummy plaques. So those comes with the, in a separate container, but they are important that not to forget them. Obviously, the radioactive plaques and forceps. You need those so you could handle these plaques as you go in. So it's nothing fancy here other than it's just something you already have done the work. It's just you have to make sure that you bring it to the OR because it's not in the same location. So this is our wonderful medical physics assistants who actually attend to these on Thursdays and on Mondays when they go up there. And just remember, iPlaque team, this is just a picture of the ocular oncologist, Dr. Shield there, Dr. Lally, and I have the radiation oncology and medical physics, nursing. I don't have but the idea there is that you have it's a multidisciplinary team, and you have to really, to establish a successful iPlaque program, it's important that you really pay attention to the communication between all of these highly specialized personnel and build the team for that. This is in TG221, really gives you a kind of a fishbone diagram, or you call it, it's a process diagram. If you're trying to start this, start looking at something like that with the team and decide with them on how the workflow, this is was a good example provided. I suggest you use it to, if you're starting a new program or improving on your program, to start communicating with this kind of thing. So in conclusion, I want to say that the dosimetry for iPlaques for ocular tumors presents unique challenges in brachytherapy. Remember, it's very steep dose gradients in the tumor and critical structures that are well within millimeters. So you're looking at it's not just the typical gynae or prostate brachytherapy. You are looking at millimeters. So this is why it's unique. In most clinical applications, the calculations of those distributions assume homogeneous water medium and full scatter conditions. But think about what is the true dose and how you want to compare it across, say, if we're going to do outcome studies relative to protons or external beam or any other modality, it's important to know that dose. So that's where we recommend calculations per TG129 and 221. And the iPlaque brachytherapy workflow spans across multiple departments. So I recommend that the communication is key for a successful program. With that, I think I want to thank you all, and if you have questions.
Thank you so much, Dr. Mourtada, for an excellent lecture. That was very, very informative. And thank you, Dr. Shi, for joining us. What time is it in China now?
It's a 3:15 in the morning,
Oh,
but my jet lag
goodness.
keep me awake anyway.
Thank you so much for joining. And that was excellent lectures for both of our speakers. Very logical, very informative. And I hope they will be very, very helpful for the Ukrainian community. So I'd like to open the floor for questions or discussions. I know one center in Ukraine, wants to start the iPlaque program. So currently there is no iPlaque programs in Ukraine. So that's a very big drawback. So we have a hand from Olena Pavlenko. You have a question? And so we would like to help the center to get it started. And thank you for these flow diagrams and charts of the processes to explain what's required, what's needed. So while people are collecting questions, I would like to start maybe with the first one to Dr. Shi. So you mentioned that around 50% of patients do lose vision, right? But it's a really great um, option against the enucleation, obviously. What is the latency period for vision loss?
Yeah, it's a good question. It certainly depends on the dose to the fovea and optic nerve disc, right? That's why we carefully measure out all the key anatomy on the fundus graph and use that for the surgery planning. The primary goal is certainly try to reduce the dose to optic nerve primarily, and we are very careful to reduce the dose of fovea. That certainly affects the acuity. And the latency period could anywhere from 6 months to a year and a half. You can see usually most of the outcome data we reported, even for the comms, are looking at a 3 year out of the implantation. And so this is a time frame we're looking at. And so we are still prioritize the tumor control over vision control, right? This is a eye preservation procedure, but we are never feasible. We'll try to reduce the optic nerve fovea dose to achieve optimal vision outcome.
Yeah, excellent. Thank you. And I was also wondering about pain management. It's very painful for the patient if the patient does not get any anesthetics. So can you talk about pain management?
Absolutely. And the procedure is done under general anesthesia. And actually, when it's placed, the pain is actually pretty well controlled. They will provide, oral pain medication and eye drops, not eye drops, just oral pain medication. And it's usually very well controlled. For removal of the plaque, actually, it's just done in the local anesthesia, which means it can be done very quickly. Patient very well tolerated. So the placement of the eye plaque is not involving lots of manipulation, but once the eye plaque is actually fully placed, the pain is actually not that severe.
Actually, one of my friends had this procedure done, and she had some contraindication to pain medication, and she was tolerating it without any pain meds. It was very, very painful. So I remember her comments, and it was I was just wondering, like, what you would do
Yeah.
in this situation.
So I think it certainly depends on the plaque size and the location. And we did mention that Dr. Mourtada mentioned that as well. The Combs plaque is actually pretty thick. As you can see the picture we use, actually we Will's Eye, our group does not use the Combs plaque. Combs plaque has the preset seed carrier, which certainly make it easier for the plaque building process. And our plaque is more like the Vivic plaque. It's very thin, has no seed carrier. So it definitely make a lot of better for the tolerability of the patient because you have a very thick eye plaque. It certainly increase our local pressure and the discomfort. For thinner plaque is much better tolerated. The complicated part of the thinner plaque we use because there's no seed carrier. So the seeds have to be hand glued to the plaque. So it depends more user experience and the quality control, but it's also allow better customization. So the pros and cons. But we prefer to use the same plaque. It's just much easier to tolerate.
That's a very good question. Thank you, Dr. Shepard. You have a question?
Yes, thank you very much for very interesting lectures. This is pleasure take your lectures for Ukrainian, and we believes that this method of treatments is our future because now we don't have experience use this method of treatments. And I also want to ask about, do you combine this plaque therapy with immunotherapy if it's need for patients, if it's, for example, multimetastatic disease, and do you have some problem with combination with immunotherapy? Thank you very much.
It's a very good question. So the program definitely evolved over time. As mentioned, the data really built on a COMB study, which is a monotherapy with iPlaque only. And the modern practice, particularly Will's eye practice we're using right now, they do try to do fine needle aspiration. It's really just tries to test for genetic high risk factors. And most of the time, those patients does not require adjuvant treatment. If it's adjuvant, they're just localized medium-sized eye plaque radiation treatment alone will be adequate. And as mentioned, the biologic behavior are very different than the squamous or cutaneous or the mucosa kind of counterpart. And immunotherapy is not routinely used in those patients. And for a patient who has metastatic disease, local therapy is still very important for uveal melanoma patient. For a patient with liver metastasis, we will consider liver direct therapy, Spheres or tracer and all of those kind of embolization treatment or ablation. And local therapy for the eye still should be considered because they are just not as good responder to the immunotherapy.
Thank you very much.
Thank you. And I have another question for Dr. Mourtada. Dr. Mourtada, you nicely explained the differences between heterogeneous dose calculation in the eye versus homogeneous TG43-based dose calculation. And you do use the iPlaque simulator and account heterogeneities, right? And then you scale the prescription. But then you do the secondary dose calculation verification using TG43. How do you reconcile the two?
So that's a good question. We actually run the Plaque simulator with the same seed. Say we have a final plan. We run it in TG43. It's very easy to turn that off, the heterogeneity off, and then you compare
okay.
with the because there is no second independent calculation with
heterogeneity.
But eventually, I think vendors are working on Monte Carlo based. You could see it, or if you have in-house. It will be there, but it's a good catch there. Yes, we don't yet do full model-based dose calculation with those.
And that's maybe a good segue for our final question. How do you envision the future of eye brachytherapy? Maybe we'll start with Dr. Shi.
Sorry, can you repeat the question again?
How do you envision the future of eye brachytherapy? So what do you hope for the future?
I think eye brachytherapy will stay as a primary treatment for the uveal melanoma. And so to supplement that, I think, comprehensive evaluation of the patient, particularly, genetic factors. And now we have some newer compound that's now coming to the horizon and for evaluation for this disease. And we recently have one FDA-approved compound that's actually looking at neoadjuvant treatment before the eye plaque. The idea is if we have active systematic agent, is it allow some shrinkage of the melanoma before the eye plaque brachytherapy. The goal is try to improve dosimetry, improve vision outcome, but there's no plan to replace eye plaque and basically can we improve the vision outcome for those patients. And the second one will also maybe allow us to treat some patient who has large eye plaque, a large uveal melanoma, historically not ideal candidate, but they may be convert into a better candidate for eye plaque with, new adjuvant treatment. But this is active trial right now. And but I do foresee, we are going to have wider indication for eye plaque patient, potentially better outcome for the patient who has larger uveal melanoma and a potentially better vision outcome for the medium-sized uveal melanoma if we can downsize them before the eye plaque.
Oh, excellent. That's great. And for you, Dr. Mourtada, what do you envision for the future of physics of eye brachytherapy?
Yeah, I'm very optimistic. We should. It is here to stay because it has. We've looked at protons, for example. We looked at other modalities, and nothing really maybe I'm biased because
Works.
I'm a brachytherapist, but it's
Yeah.
really simplicity, cost effectiveness, and it's important. This is I think for Ukraine will be perfect sense. We could teach this. Ruthenium eye plaques are there in Germany. So you could get those. I'm happy to start there and think about the future. I think the future for your people there is to start doing what we do with the ruthenium plaques. It's wonderful. I've had 10-year experience with it. If you can get iodine, that's maybe but to me, it's you have I think the future is bright for brachy. I don't think it's going away, like Dr. Shi said. I think we need to train your physics residents or faculty there to actually understand these concepts. I don't think they are. It's not that difficult to implement. You just have to. I emphasize on team communication, and you are a wonderful communicator. I can't imagine how anybody could do it better than you in terms of putting teams together and make this happen. And that shows because you have 10 wonderful brachytherapy lectures already that I think everybody should see them. So not just Ukraine. So thank you.
Excellent. Yeah, thank you so much. So that's a very good high note. Srihi, did you have any comment or questions?
I just wanted to thank very much for very interesting lecture. I would agree that this is very unfamiliar for us topic, and I'm very happy that you will have at least one team that is eager to learn the technique. It would be interesting for me to know, in your opinion, like how many centers out of 10 or 20 should, or in your experience in your country, do use this technique. And yes, so about the teamwork, what is your advice on how to build a good team for that, and what time training should take for this technique?
3 questions. Okay, how many centers across US you think using it? Is there any statistics?
I don't think there is ABS statistics. We did not count them, but if you look at the rate, it's 1 in 5 million, right? So, I mean, one occurrence of ocular melanomas in 5 million. So obviously, I mean, Ukraine is a small country. I can't imagine you need, I mean, I would say no more than 2 centers, maybe 3. So you have to look at your epidemiology, look at your statistics from how many patients would have benefited. I think the surgeons would know those numbers, right? Because they're going to enucleation already. But if you could offer that, I think that's the key. I don't think many centers. Because it's just it's such a low rate unless you're bringing them from. I mean, even at MD Anderson, when I was a very large institution, we did not. Maybe we treated 3 per month. I don't know at Stanford how many do you know how many you do?
It's approximately the same, 3-5 per month. Yeah.
Okay. So yeah, it's the feed pattern, and I think it just Will's Eye is not the right model because that's very internationally. It's coming from South America, it's coming Europe, Asia. We see patients from everywhere. So that's why we are having 6 to 7 per week. I think for you, you're probably gonna.
We'll start maybe from one center and see how that goes.
How it goes, yeah.
And then, just to follow up on Srihi's question, he had 3-part question, but is there any good school that you can, or workshops that you can attend specifically for ocular brachytherapy? Are you aware of any? Or maybe you will organize one?
The Will's Eye has a ongoing international fellowship program.
Okay.
So we always have 1 or 2 international fellow in Dr. Shu's office and working in the OR, and they usually spend up to a year. And those fellows come from all over the world, including the most recent fellow come from, I believe, like Indonesia. And we have a lot of fellow coming from India. So there certainly is the observation fellowship or the clinical fellowship program opportunity at Will's Eye. And actually, our department will have visitors from Ukraine going through our department. They're obviously just observing the general radiation oncology practice, not the eye plaque part.
Yes, yes.
But certainly that is another opportunity there.
Oh, excellent. Thank you for hosting them. That's really great news. Thank you. Thank you. That was a excellent lecture. And so this is our last lecture. So on behalf of Help Ukraine Group, American Brachytherapy Society, and SweetCare, I want to really thank our amazing speakers today for outstanding and very comprehensive and interesting lecture. And thank you, Dr. Shi, for waking up in the middle of the night to be present with us. Thank you. We really appreciate
Pleasure
it.
to be part of this.
Yeah, thank you so much. And thank you to all our listeners and participants to attending and answering questions very diligently. That was really nice to see how you correctly answered the questions. And so I want to just remind everyone, this is our final lecture, and we will be sending out an email with the link to the exam, post-course exam, and please complete it by Friday. So we'll give you the deadline, and there will be also evaluation form. Please complete it timely manner. And I just want to announce that our future steps from the Help Ukraine group side, that we will be organizing cervical cancer brachytherapy course. It's a hybrid course that will start March 15th next year. And Dr. Lesa Metzak is the director for this course, and we are currently going through translations of the lectures. And we will also be sponsoring Easter brachytherapy course participations for Ukrainian attendees. So please follow us on social channels, and then watch the news from our group, Help Ukraine Group. So thank you again to everyone for the dedication and for your investment of time in your professional growth and to serve Ukrainian patients better. Thank you. Thank you, everyone.
Bye-bye. Thank you.
Goodbye.
Goodbye.